All right, so artifacts, if you do have the fifth latest edition, it is in chapter 8. And then if you have the fourth edition, you are going to be looking at chapter 7. So we're going to be working off of 2 documents today. Share screen. So I updated this document here. It's called the MRI artifact chart. So this is the main one we're going to be going through today. But I also have an artifacts PowerPoint, which kind of shows you different examples of these particular artifacts. So it kind of gives you more of a visual representation. But what we're going to be really just going off of today and going through for these next 2 weeks is this chart right here. I would love for you guys to print this off, because this is one of those documents that would be very helpful when you're in clinic, so that you're able to recognize an artifact, see which axis that artifact is traversing along, and maybe have some ways of reducing or eliminating that artifact. So you guys just have a quick reference, print it out, and have it in your clinical notebook. Obviously, you're going to need this to study for the exam, but it's really helpful. This, because not all the things that we cover in class are really that helpful when you're kind of in clinic, but this chapter is a huge help when you're in the clinical setting. So just a little tip. I hope everybody's kind of compiling a nice, thorough clinical notebook. All right. So everybody able to see my screen? Okay. All right. So I'm going to minimize this.
Sean, I made a copy of it, but mine is a little bit different from yours. I don't know. Did you change it?
It's recent, Nushina. So I did it a couple weeks ago, but I forgot to download it into the modules. So last night I was like, did I put the more updated one on the modules? So if you print it out like 2 days ago, you're going to need to reprint.
Okay, sure.
I printed right now, but it gave me the different pages, and some of the pages is gone. I don't know.
You're going to have to adjust the settings, because this is a very large, because it's just a big chart. So I had to like expand. It's almost like in a poster board format. So you're just going to have to change your like printer settings to kind of get it all on one piece of paper. That I even struggle with sometimes. So just maybe, you know, ask somebody that's super computer savvy. But just, I know when you go into print, sometimes they give an option of print like at 100%. You might have to reduce that down to like 70% so it all gets on one page. And make sure it's landscape, not portrait, because it's mostly crosswise. All right. So today we're going to be talking about different artifacts that you might come across when you're imaging an MRI. So we have about 15 artifacts we need to go through. I don't know the exact number. But artifacts are sometimes things that we can compensate for. Where when we're talking about compensating for, we can basically fully eliminate them so that they don't show up on our image. Some artifacts, unfortunately, we can't fully compensate for, so we need to think about some workarounds. And sometimes you really have to just think about the anatomy of interest, and is that artifact going through that anatomy of interest? So we have ways of kind of changing our parameters on our MR console to say if there is a flow artifact from the abdominal aorta and it streaks across our pancreas, and that's where that tumor is, maybe we need to think about maybe switching our phase and our frequency directions, just so that artifact, which we can't fully compensate for, just doesn't go through the anatomy of interest. So sometimes we can fully compensate for these things. Sometimes we, unfortunately, just because of the way that the MR system is set up, how fast you're scanning, sometimes we can't fully compensate for those artifacts. So you have to think about what are some ways to work around it. We also have to take into consideration our patients. Some patients we know are a little bit better at following directions, We also know that patients are sometimes claustrophobic. So we need to adjust our parameters just to get a scan done in some instances. So a little bit of artifact is okay because we were able to get something compared to nothing. So we have to kind of think about that too. So we know back from our parameters chapter that MRI is this constant juggling act, where just when you think you're getting great signal and resolution, something happens in the scanner and the patient moves, and then your image quality is all screwed up. So we know we have to constantly juggle signal to noise ratio, resolution, and our scan time just to get a very quality MR image. All right, so let me describe what you see in this chart. So over here are the artifacts. So the first column here is the actual name of the artifacts. And it's very important that you know their synonym, or basically another name for that artifact. So the first artifact we come across is called phase mismapping, but you might also see it called ghosting or just simple motion artifact. So the registry and my exam can use these terms interchangeably. So you need to know that phase mismapping is ghosting and is also motion artifact. So that is your first column. That's just the artifact's name. The second column is the definition of that artifact and what is causing that artifact. So we're going to have a brief description of really the root cause of that artifact. The third column here is the axis. That is, remember our MRI image typically has two axes, and one is the phase and one is the frequency. And typically the phase is going to be your smaller axis or shorter axis, just to keep scan time down. So just think of your axis, think of it as your field of view, right? You always have, a vertical axis and a horizontal axis to that rectangle or that square image. You'll also have one other selection for axis, and it's called the slice select axis. And I'll go over that when we come to it. But we have three options there: phase, frequency, and or slice select. These artifacts can occur in multiple axes. So you need to just be mindful of where these artifacts occur and what axis they occur along. All right, and then the fourth column are going to be some examples. So you'll see some images or also some other just written examples and a brief description of the appearance of that artifact. And the final column here is your remedy. How we can compensate for those artifacts. So this is the column I really want you guys to be very mindful of, because this is what's going to separate a good tech from a great tech. Okay, we're not just button pushers, right? Just like in X-ray, we're not just button pushers. The MR system is getting smarter and smarter to the point where the AI technology is able to localize where the brain is. It can, even with the AI technology, even sets up your slices sometimes because it can detect where that anatomy lies in the scanner. And then we already know that the physicist sets up these protocols. And if it was a perfect patient, sometimes in the MR system, you can basically lay them on the table, grab that protocol, swing it over to the left, download it, and run it. And you would probably get some decent images. But what separates a good tech, or maybe even just an average tech, from a great tech is really how we can compensate for these artifacts and how we can improve image quality, how we can improve the experience for the patient, things like that. So that's why I think this chapter in particular is a really great chapter on improving your clinical performance. All right. All right, so now that we have the columns, you can see here that each page is going to be a different artifact. On my previous chart, I really had, several artifacts on each page, but each page is dedicated to a different artifact so that it makes it easy for you. So if you are able to print it out in a format where you can see it in a landscape mode, it will make it really easy for you to flip to that particular artifact and know some ways to compensate for it. All right, so let's start her off. Any questions about how the chart's set up just to begin with? Nope, okay. Are you guys able to see my screen? Do you need me to like blow it up a little bit? Because I could probably zoom in a little bit better. What's your feedback from your side? I can go in a little bit more if that's helpful.
It's fine. I can see.
Okay. I'll keep it at about this 150% so that I can just kind of.
Yeah, that's good.
Okay. All right. So the first one we do come across is phase mismapping, also called ghosting, also called motion artifact. Okay. This is one you'll come across a bunch throughout your MRI clinical time. Not only clinical, but once you get out there as a working technologist. Because we know that the patient has involuntary motion along with voluntary motion, right? So there are things that the patient can't control, like breathing and motion. But there are also involuntary motions within our body, like peristalsis and the heart beating. Things like that are involuntary motions. So those are things, once again, we can't fully compensate for because you need your heart to beat for you to stay alive. So we can't fully compensate for all the time. What we're really going to be talking about is compensating for that respiratory artifact or that respiratory motion and some of that flow motion that we get from flowing blood and CSF flow, which we talked about a little bit last chapter. Okay. So by definition, phase mismapping occurs when the anatomy has moved during time delay between the phase encoding being switched on and the readout gradient being switched on. Okay. So this is a little bit of just a kind of a simplified version of our pulse sequence diagram right here. So our first line here, we could say is our RF pulse. Our second line is our phase encoding gradient. And our third line is our frequency encoding gradient, which is also called the readout gradient. So what we're talking about with this particular artifact is that anatomy has moved between the phase encoding and the readout gradient. Okay, so I'm going to select that here. So this is our first phase encoding gradient right here, which typically occurs after our excitation pulse. And then this is our first readout gradient right here. And I always kind of draw right in the middle because we usually sample at peak echo, which occurs right in the middle of that readout gradient being turned on. So let's imagine that the patient has taken a deep breath in right as our phase encoding gradient turns on. Okay, so on inspiration, all right? And we know typically these things happen very rapidly, but the patient can't hold their breath. Maybe they're unconscious. Maybe they just don't follow directions very well. Maybe they're in a lot of pain. Whatever's causing them to not hold their breath between this time and this time will create this artifact. So let's imagine, once again, this is inspiration when we turn on the phase encoding gradient. But by the time we refocus our signal and then we collect our signal, we are on expiration. So we're on inspiration here, we're on expiration here. So you can see that our phase has changed between those two times. And if our phase changes positions by the time we sample it, it's going to get misrepresented on our image, or what we call misplaced in the phase encoding direction. Okay? So it's important to remember that the frequency axis is where we basically collect and digitize the signal. So no mismapping is going to occur in the frequency axis because we're just collecting the signal here. Okay? And our phase encoding step does not change each TR. So remember from our pulse sequence and our encoding chapter that every TR, our phase encoding step, changes depending on the amplitude of that gradient. So the artifact occurs in the phase direction because that's the only thing that's really changing each TR. And if we do not collect our signal without any motion, it's not gonna, let me change my phrasing on that. If the anatomy changes position between these two times, it's gonna misrepresent on our image. That's gonna look something like this, and it's gonna incur in the phase direction because that's the only thing that changes each TR period. Okay? So it's really important to remember that the frequency encoding, that's what FE stands for, and the slice select gradient are going to be at the same amplitude. We turn those gradients on at the same amplitude each TR. And that differs with our phase encoding gradient because our phase encoding gradient changes amplitude each TR. All right? So then let's move over to axis. So that explains why you'll see this artifact occurring in the phase axis. Okay, so it's important to just remember this occurs in the phase axis. So appearance, this produces replications of moving anatomy across the image in the phase direction. Okay, so here is an example of that. And so we have an abdomen. This is an axial slice. And you can see that the anatomy, as the patient breathes in and out, is getting mismapped across our image in the phase direction. And I know this is the phase direction because remember, we said we usually want the phase direction to be the shortest axis. So if I measured this out from A to P, this measurement should be less than if I measured out right to left. Okay. So in this instance, the patient had breathed in and out. They were not able to hold their breath between these two times. So if I took my marker from here to here, let's say that was only like 4 milliseconds. That seems short, but remember, our patients sometimes can't hold their breath at all. So if they're not able to maintain that breath hold between these two times, this artifact happens. Okay, some other examples of this artifact would be not only just the chest and abdomen wall during respiration, but we have pulsatile movement of vessels and CSF. So think flow phenomena and CSF flow. Think swallowing, like in a sagittal C-spine. If the patient is swallowing while you're scanning, that's going to cause motion of the esophagus that will streak across our spinal canal. Eye movement. Your patient, when they go into the scanner, especially when you're scanning the brain, they might keep their head completely still, and have their eyes closed. But what they're doing sometimes, as they're thinking about different things, they move their eyes a lot. And that eye movement will create these phase mismapping artifacts streaking across the phase direction of the image. And then other anatomy that moves periodically through the scan. So think of peristalsis, cardiac motion from the beating heart you could put there. Those are other examples. So what is this example of? So we don't have the chest wall moving, but what is this right here?
It's the abdomen, right around the liver.
Yep, but what's this artifact streaking across the image? It's a phase mismapping artifact, but what's it mismapping from? Is it
The spine.
the what's that?
Spine.
I can't hear you.
She said the spine, but
Spine. Okay, so the spine usually stays in the same spot. Here's the spine. So that looks like either a T-spine or a L-spine, the very like L1. So the spine's going to stay in the same spot typically when you're scanning. But what do you think is right over in this area? What is it? There's a structure that is a little bit anterior and a little bit to the left.
Aorta.
The
Abdominal aorta.
So this is what we talked about in last chapter. This is that flow phenomena artifact, because once again, we have flowing blood that is going to change phase positions between the phase encoding gradient and the frequency encoding gradient. So remember, we talked about several remedies. We had gradient moment nulling we could do. We could put sat bands above and below the field of view. Those are some remedies, and we'll get to that. So that segues us right into our remedy column. So there are some immobilization methods to reduce motion artifact. And this is really dealing with like extremities, right? Like if you're scanning a foot, it's really important to make sure you really pack that foot into that coil with a bunch of sponges, because patients, they do think that they hold still throughout the scan, but sometimes just even the slightest motion will create this artifact. So it's always real important, if you can, use some type of a mobilization method. And that's typically sponges in MRI. We could also change how we fill K-space, and you'll see this particular K-space filling method chosen a lot if you have a patient that has a lot of involuntary motion, or they might be a sedated patient where you're scanning the brain. But K-space filling in a blade or propeller method really helps to compensate for that. And I'll show you how that K-space is filled here shortly. We could also swap our phase and frequency direction. It does not, it's important to put a little asterisk over here. It does not eliminate the artifact, but let's just say that artifact is in the anatomy that we're trying to look at. So here, it's streaking across, and let's say this lobe of the liver right here is where that tumor is. What we could do is just swap our phase and frequency. So instead of this being the phase direction, we can now make this the phase direction. And that artifact will go from here in the aorta, and it will streak across our image this way. Okay. Once again, we're not fully eliminating that artifact, but we're just getting it out of the area where that tumor is, so that the radiologist can see really what's going on. So that's an option. Not the best option, but it's an option. We could do sat bands. Remember, we could put sat bands above the field of view, below the field of view, and we can even put them inside the field of view. The only place you don't want a sat band, remember, is over air, because all that's going to do is heat up the patient, because we're just applying additional RF pulses. We could turn on our gradient moment nulling, also called gradient moment rephasing, or even flow compensation. We have 3 names for this particular type of parameter adjustment. And this is something we just select on our console. Typically, flow compensation is the name for GE, and then GMN is for Siemens. And remember, this is just that additional bipolar gradients to put the flowing spins back in phase. So we apply a positive lobe and a double negative lobe and another positive gradient lobe so that the flowing spins have the same phase position as our stationary spins. And we need to think about, do we turn it on in the frequency mode or the slice mode? And remember, frequency mode is in plane and slice mode is through plane. So this situation right here would be what we call through plane or slice mode. Okay. Another option for remedy is respiratory compensation. So we have, you can turn on your navigator and kind of see where that liver and that diaphragm's going as you're scanning. You guys might have done that when you're doing your MRCP, doing your abdomen. And that's just like a little box where we put it right, you know, half of it on that dome of the liver, half of it into the lung, half of it into the liver, so that the system knows how the patient's breathing in and out and can adjust for when to scan at appropriate times. Or you can also use these respiratory bellows. And then look at these bellows. It's just, these are air-filled, but it lets the system know when the patient's taking a deep breath in, when they're blowing it out. And typically, when you're using this respiratory compensation, the MR scanner is going to scan when they're on expiration. So you breathe in, you breathe out, wait a second, and then it scans. Beep, 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 beep. Breathe in, breathe out, beep, 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 beep. So you know that there's no motion on expiration. And they don't want to scan on inspiration because everybody's inspiration is different each time. So instead of going scan it, breathe in, scan, beep, 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 and then breathe out, it's always on expiration. So that is also called gating, respiratory compensation or gating. And then the last method of remedy for this artifact is increasing our next. So this is number of excitations. That's what this acronym is, number of excitations, or number of signal averages. They mean the same thing. They're interchangeable. Okay. So what's happening with those number of excitations? It's basically you have K-space, you have all the different rows that correspond with your number of phase encoding steps. If you have one next, you're just going to fill every row of K-space with signal one time. So you collect per TR period one echo. Then you go down the next column, a row, and collect another echo. And you just simply fill out K-space in that fashion. But if I increase it now to 2 next, basically you go back in and then you fill that same row with another echo. So you have more signal within that row of K-space. And what's great about this is the mismap signal, or basically the mismapping of those phase shifts that create those ghosting artifacts, they're somewhat randomly located on each signal average. So let's say that phase mismapping artifact is over here on that first echo that we selected, like right in this area. And then the second time around, that phase mismapping artifact isn't there, or it's maybe over here. So as you increase your next from 1 to 2, it basically averages out that artifact. So that is a positive to increasing your next. But do you guys remember what the negative to increasing your next is?
Scan time.
Scan time, exactly. So as you go from 1 to 2 next, your scan time is going to double. So even though you might average out that artifact, you're going to double your scan time. And if you double your scan time, you might reduce that artifact from, let's say, a flow artifact, but then the patient's more likely to move during an 8-minute scan versus a 4-minute scan. So you have to kind of always play that game of or juggling in MRI to get the best image quality. So mismapping of signal creates ghosts that is somewhat randomly located on each signal average, and it becomes less apparent because it averages out of the image with an increase in your number of signal averages. So pros and cons to this one. So many different methods to remedy that artifact, okay? Let me see if I have a picture online about this blade propeller. Let's see. All right, so on this MRIshark.com, there's a great section of how different ways you can fill K-space. And we talked about this in our encoding chapter: linear, centric, spiral, but radial. This is the one we're going to be talking about with this blade method. So radial, blade, propeller, this helps reduce motion. So it says radial K-space filling is used as a way to reduce motion by collecting data like cutting a pie into slices. We are able to remove motion in our slice plane, okay? So basically it just kind of rotates at K-space as we input our echoes into K-space. And so it's really good as it rotates and it creates this like inputting data as these slices like we're cutting into pie. It helps with a patient that might be rotating their head right and left. So that's why it's so great with patients that are unconscious and you're scanning their brain and they're moving their head right to left. It might just be just this involuntary tick, but it will help compensate for that motion. So that's what this radial K-space filling is all about. All right, any questions about phase mismapping? Also called ghosting, also called motion artifacts. So here, let me just show you some other images of it. So you've already seen that one. So here we have motion from the vessels of the heart, and above the heart, you can see here. So we have like the aortic arch, we have the pulmonary arteries and vessels. So we have a lot of motion kind of from the chest, but mainly this involuntary motion coming from the cardiac region. So you can see here that they originally had the phase encoding direction going up and down, and that artifact is not as pronounced as when they had that phase direction going right to left. And see how it's streaking across their image here and into the lungs. So if they were looking at the lungs for anything, this would be the better option because you can see that they're able to see those lungs a little bit better. So it's all about what area they're trying to look at sometimes if you just want to swap the phase and frequency. This might be the better option if you're looking at the spinal canal in the spinal region or at the sternum. Right? You might see it in the coronal brain here. So our phase direction is going right to left in this instance because you can see that artifact streaking across right to left. And the patient's just simply moving their head while you're scanning a coronal sequence. So a good remedy for this would be the blade or radial K-space filling. Or maybe immobilization. Even when you put them in the brain coil, it's nice to pack their brain head into the coil with a bunch of sponges. Here, this is really a flow artifact. So we talked about this last chapter. So this is a posterior cervical Willis flow artifact. Let me zoom in here a little bit so you can see it a little bit better. So we have over the cerebellum, we have this posterior cervical Willis creating this flow artifact coming across the image. So you can put the signal from the flowing blood back into those vessels by gradient moment nulling or flow compensation. That'd be a great remedy. And here is our patient not only breathing in, so you can see like the trachea, but also swallowing artifact. So we have a sagittal C-spine, and we can see all this motion artifact streaking across our image in the phase direction, which is A to P, because here's anterior, here's posterior, so the phase direction is A to P, frequency directions head to foot. And so we cannot see that spinal canal as well as over here. So if there is like a syrinx or if there's a herniated disc, it's hard to tell for the radiologist what's going on. So a good remedy for this would be, let's put a sat band. Remember, we can apply an extra RF pulse so that we fully saturate all those tissues underneath that RF pulse so they don't streak across our image. You could also swap your phase and frequency direction. Instead of the phase direction going this way, now put it head to foot. You just might have to put some oversampling on. So there are some options to improve your image quality here. So I always put the remedy down in the notes section. All right, here we have our respiratory artifact. So the image quality is not too bad, but we can see that artifact streaking across the liver here a little bit. So to improve this, they turn on this gating or respiratory compensation. And like I said, usually the scanner will start scanning when they breathe out. And there's this moment where the chest wall is not moving at all. So the scanner will wait until the patient breathes out, and it won't scan during this time. But during relaxation, the scanner will be on during all this time and collect data. But then it'll wait a little bit longer because the patient has those respiratory bellows on, so it can tell when the patient's breathing, and then it will scan again during this time. So the only downside to this, once again, is your scan time is going to go up because it's not scanning continuously, it's scanning on expiration. If the patient's able to hold their breath, though, that's the best option. And then here is just, well, it's not a swapping phase of frequency. They put sat bands above and below the field of view. So we don't get that flow artifact. And then look how pretty it is over here. So we have the signal that is getting mismapped from a abdominal aorta. And then they put a sat band above because that flowing blood's coming down from the heart. And we no longer get signal from flowing blood, but it also doesn't create an artifact streaking across our image. This is just another example of that sat band on a sagittal C-spine, because look at this flow artifact and motion artifact. That could look, it mimics pathology. So this looks like a syrinx in the spinal canal, but then we add that sat band and it looks nice and cleaned up. Okay? All right, any questions about phase, mismapping, ghosting, or motion artifact? All right, next one. This one's called aliasing or wraparound artifact. Okay, so by definition, this is where anatomy outside of the field of view, so on these images, the yellow is the field of view, still provides signal if it is in close proximity to a receiver coil. So imagine your receiver coil for an abdomen, we know we usually put a receiver coil on top of the patient, and then usually there's one in the table or behind the patient. So all this tissue is in close proximity to those receiver coils, okay? So data from signal must be encoded or basically allocated a pixel position. So even though this is our field of view in the middle here, we're still getting signal from the edges of the abdomen. And those phase positions need to be allocated a pixel position. So if the data is undersampled, basically meaning our field of view is not large enough, the signal is mismapped into pixels within the field of view rather than outside. And the reason for that is because we get phase wrap, because we get duplication of phase values. So look at all the directions of these arrows. And particularly this second diagram down here, just keep the receiver coils in the same position. You can see that the phase values of the anatomy outside matches the phase values of the anatomy inside, but on the opposite side of the field of view. Just because of how the gradients are set up and it changes our phase position of our spins, it just happens that they match up on the opposite side of the field of view. And the reason that the anatomy from outside the field of view wraps into the inside of the field of view is because they have the same phase positions, the exact same phase positions. Okay? So you can see it here on the other side as well. So on the patient's left side, it wraps into the right side of the field of view. All right? So before we get into frequency wrap, this is what it looks like with phase wrap. So I want you to highlight, it's both frequency and phase, but I'm going to talk about frequency wrap here in a second, but most of the time the MR system compensates for that. So just go ahead and just put under here, the MR system usually compensates for that. So most of the time what you guys see is a mistake by us by not oversampling the data and making sure our field of view is large enough so that we don't get this wrap of the anatomy. So and that's going to occur in the phase direction. All right, so the appearance is anatomy that exists outside of the field of view is folded on top of the anatomy inside of the field of view. So here, I honestly can't even tell what they're scanning because anatomy is wrapped all over. It looks like maybe the abdomen here, and then this is like some of the arm or the other side of the abdomen. Maybe this is like kind of soft tissue pelvis. It's really hard to tell. Here we have a foot scan where this is very common, where they did not put on oversampling or have the field of view large enough, and the ankle wraps into the forefoot. Here it's a little simpler to tell what's going on. They're scanning the L spine, and they didn't turn on phase oversampling, right and left, and you can see that the left side is now flipping into the right side of the anatomy is flipping into the left side of the image. And the same is on the other side. So those are 3 examples of phase wrap or aliasing. Okay, so when we're talking about compensation methods for phase wrap, we could simply just increase our field of view. So a very common example of phase wrap is when we don't have a field of view large enough and the nose on the sagittal wraps into the back of the image. Who's guilty of that so far? I know everybody should raise their hand on this one, right? And that's not that bad because sometimes that nose is only like right here, right? So as long as it's not in the anatomy, you don't have to like repeat the scan. It's just knowing what is causing that nose to go, instead of being here, why is it back here? And that's because it is the same phase position as back here. And remember, your whole head is in that head coil, that brain coil. So you're going to get signal from all of this tissue. So you just, unless it's sampled, it's going to be misrepresented into your image. So you can increase your field of view. We know that there are downsides to this. So if you increase your field of view, what happens to you if your matrix stays the same and you increase your field of view? What happens to your resolution?
Decrease the resolution.
Good, because your voxels or your pixels are getting bigger. So it's going to reduce that artifact, but then your resolution is going to go down. So sometimes a better method is to put a sat band here, because once again, you nullify signal from underneath that. Or probably the better option is this no phase wrap. So we know the phase wrap, no phase wrap typically just extends past the field of view in the phase direction so that we are sampling that data, but what happens, it still gets wrapped, but it gets put into this extra little rectangle here that never shows up in our field of view. Okay? So GE usually you could just turn on no phase wrap. Siemens gives you like a percentage typically with the phase oversampling, and you might see it on a different scanner called fold over suppression. So that might be like on a Philips scanner. But all those are used interchangeably. We could also increase the number of phase encoding steps. So if we increase the number of phase encoding steps, we're also going to increase our resolution, which is good, two good things. But the only downside is it's going to increase our scan time. So not always the best option. Or we could select a smaller coil. So if you're scanning the wrist, you don't want to put a large abdomen flex coil over the wrist because you're going to get signal from, let's say, the forearm also. And we know that smaller coils typically get more signal than larger coils because they're closer in proximity to that body part. Or we could use what we call a transceiver coil, where it's a transmit and receive coil. So you need to be conscious of your transmit receive coils in your department, because a transmit receive coil is pretty cool because it is able to transmit RF frequencies or RF pulses and energy to a very local area. So if you have a transmit receive head coil, you can basically excite and collect signal just from that body part. Compared to what they call the body coil, and the body coil basically sits within the gantry of the scanner, and if you turn on the whole body coil, you can basically get signal from the entire patient. So a transmit receive coil, also called a transceiver coil, is what we call a local coil, because we can transmit and receive signal just from a very local area, so that we don't excite an area that is not needed in our MR image. So if you're just scanning the brain, obviously we wouldn't want information from like the neck or the body. Okay. So that is phase wrap. So let me just quickly mention frequency wrap, just because it's on the registry, but the system automatically compensates for this. So let me just put this out there. So if you see something like this on your MR image, it's going to be phase wrap. Okay, so you need to think about how you change your setup in terms of phase wrap. Frequency wrap is just the system undersampled frequencies present in the echo. So going back to that Nyquist theorem, where we didn't sample our RF frequency enough to get good quality data, that's what happened. So the Nyquist theorem was not obeyed. So it was more like this, where they just sampled it once compared to sampling it multiple times per cycle. And you get misrepresentation of the data in the frequency direction. So the system compensates for it by applying this digital filter. So that's all you need to know about this. It basically, for frequency wrap, the system automatically applies this digital filter. It compensates for frequency wrap. It increases the number of data points or sampling points. And it's really only going to be concerned with those particular data points that are related to the central frequencies are going to be displayed. So this is just showing you an image of what the system's doing. It's basically, these are the frequencies we're going to sample, and we're only concerned with the center. So once again, though, this is automatically compensated by your MR system. So you need to be more concerned with phase wrap. All right. So let me just show you some more examples of phase wrap. Here's a great one from the sagittal brain. You can see that our field of view wasn't large enough, and then the back of the head wrapped into the front of the image. Usually it's the other way around. The nose wraps into the back of the head. So here, field of view not large enough, nose wraps into the back of the head. And in this instance, they turned on that phase oversampling, those extra rectangles that surround the field of view. We're sampling this data, so it's not going to be mismapped into the back of the field of view. Here, which direction do you think is the phase direction? Right to left or A to P?
A to P.
A to P, yeah, because this is the front of the brain, right? That's up here, and this is the back of the brain that's normally down here and gets flipped up here. So we know that this is the anatomy from outside the field of view that's getting mismapped into the top of the image and the bottom of the image. And we know just this is an axial slice of the brain. This is A and this is P. This is right, this is left. So we know the phase directions A to P. Another great example. And you're thinking, why would they ever want a field of view so small? But remember, we are scanning sometimes not the entire brain, but we're looking at a very specific area. So do you guys remember on a sagittal thin slice of the pituitary gland, typically our field of view is a lot smaller because we're really just concerned with this area. So we want better resolution. So we need to have the smaller field of views, but remember, we need to make sure we turn on our oversampling. Okay. All right. What do you think we have here? What area of the body is this, just to try and guess? What do you guys think?
Is it the leg or the arm?
I think it's the leg. So like the femur, I think, kind of getting close to like the knee, but I think it's the femur. It's tough to tell. But remember, with the femur, we typically lay that abdomen coil on top of both legs, right? So what's happening is this leg is also has signal coming from it. And what's happening is this leg typically looks just like the other leg, and it's getting mismapped into our field of view. So we have two legs we're scanning. We're not trying to give our patients discount imaging. We're not trying to 2-for-1 specials. That does not happen in MRI. So make sure you guys don't put two anatomical structures in one image. So we can see how it's impossible to read. All right, and then this was that example of the forefoot and the heel. So in this situation, if you kind of can't really understand what's going on, imagine the foot is like this. And we know that we usually divide up the foot and ankle when we're scanning, or at least those that have been to MSK sites, and we'll talk about it today in lower extremity. But if you're just scanning the forefoot, like the toes back to the tarsal bones, if you don't turn on your oversampling, that heel might wrap into our image. So I can see here, since it's like a taller structure, I'm pretty sure this is the heel. And then this area right here is that 4 foot.
I have a quick question, Sean, because when I was doing that, your oversampling kind of can cut into your time. So I would take the percentage down. How much percentage do we need to have in order for it not to wrap?
That is a great question, and it depends, right? So, all right, so let's give this scenario again. So imagine this is our field of view, this first box. Okay. Let me change the color. Let's go with green. All right, so we need oversampling, right? And oversampling, let's say the phase direction is, since this is A, this is anterior, this is posterior. Our phase direction is going A to P, okay? So when you turn on that oversampling, let's say we give 25%. It's always 25% of the field of view, okay? So imagine that field of view is 100%, 25% would look something, I'm not being exact, but something like this, okay? And we always get it on both sides, so it would be something like this. All right, so if you think that if you have 25%, and then you have to think if you have 25% on the other side, so you can almost double that here, it's still not enough, because that heel, we're still getting signal from this area that's going to wrap into our image, okay? So you always basically have to just clear the anatomy. So with a Siemens scanner, just make sure with the two combined on either side, it clears the anatomy in that direction, or else it's going to wrap into our image. But great question. So I would, instead of 25%, maybe knock it up to 50%, so that, you know, I get the combination of the two 25s and then this, and then that basically goes all the way out to here. And then there's nothing back here, right? It's all just air. So there's nothing that's in danger of wrapping into our image. Or simply with this scenario, Shamarva, let's just flip our phase direction. Instead of going A to P, here's superior, here's inferior. And we're going up and down now. And look, outside of our field of view, there's nothing here, and there's nothing here. And then, because phase oversampling adds time to your scan, because you're now sampling more information. You're almost adding phase encoding steps. You are adding phase encoding steps. Okay, so sometimes the best solution, if you have a patient that is moving or claustrophobic, let's just switch our phase and frequency direction. Get rid of that scenario altogether. Great question. All right. Does everybody understand the percentages now? You don't get that luxury on your GE scanner, unfortunately. You kind of get that luxury on your Siemens scanner. I know the newer software GE, if you're up at Johns Creek, they do percentages now. But I don't think anybody's been to Johns Creek yet. All right, next artifact, moving on, chemical shift. All right, so chemical shift, and there's a unit that's applied to chemical shift. And what ppm is parts per million. That's what ppm, then that's the unit or the value associated with the amount of chemical shift. So that's a very common registry question. What's the unit of chemical shift? And it's parts per million, ppm. And this is field strength dependent. And we talked a little about that last unit, and talking about mainly the two biggest tissues that we're always concerned with in MRI. So we talked about how fat and water have different processional frequencies. We know water processes slightly faster than fat. So their Larmor equations are going to be a little bit different. in terms of megahertz, but when we're talking about hertz on a smaller level, it's actually a little wider than we think. So when we're talking about processional frequency, the unit we talk about is megahertz. But if we simplify it down to, or reduce our scope, and we just put it in units of hertz, the processional frequencies actually vary a lot more. So you can see this is units of hertz versus megahertz. So we said fat processes slower than water due to just its chemical makeup, and that's field strength dependent, because remember the Larmor equation, it was always the gyromagnetic ratio of a particular tissue or element times B sub 0, which was our which was our static magnetic field strength. So at 1.5 Tesla, here we have on the left, our chemical shift between fat and water is 220 hertz. So water processes 220 hertz faster than fat. But at 3 Tesla, we have a higher strength magnet, so that chemical shift actually spaces out. And now we're at 440. Okay. So with this difference in processional frequency between fat and water, sometimes it causes them to be placed into different pixels in the image. Okay. So before I go down here and talking about receiver bandwidth and a way to adjust that. So this is going to occur in the frequency axis. Okay. So the frequency axis is typically the longer axis, not the shorter, the longer axis. Its appearance is dark edges, bright edge, where you have an interface between fat and water. A very common area is going to be our kidneys, because we have fat and water within those structures. Typically in the peritoneum, there's a lot of water, fluid, and then the kidneys are mostly comprised of fat. So where you have the fluid from the peritoneum coming in contact with the fat from the kidney, this chemical shift artifact is going to be most pronounced. And what it looks like is one side of the structure of that kidney is going to look bright, and one side is going to look dark. So remember, our frequency direction typically on an abdomen is going to be right to left, because this is the longer axis of the anatomy compared to here, it's a little shorter. So that's why this occurs in the frequency direction, because we're dealing with processional frequencies. All right. So that's one situation in the axial kidneys. And another scenario could be something like this, where you have fat from the spinal canal kind of surrounding the CSF fluid and the thecal sac. And then you have fluid in the actual spinal canal. So here, there's a dark band on this side, and you can't really see the bright band here because it basically runs up right against that CSF fluid. So we have a white band. So dark band on this side, white band on this side. All right, you could also see it in MSK imaging. So here we have a dark band in the front of the knee that looks like cortical bone, but then we have this bright signal on the posterior aspect of the knee. Okay, so the radiologist is getting confused. Is like, why is there some kind of pathology causing this increase in signal? Is there some kind of pathology causing this lack of signal or increase over here? Is there some kind of tumor on the front of this kidney? What's going on? What's causing this artifact? And it's really not pathology. It's just this chemical shift artifact. All right. So this is one of these artifacts you're not going to be able to completely eliminate, because remember, fat and water process at different processional frequencies. We can reduce it to the point where your eye might not even pick it up. Something we can't really completely eliminate. It helps when we scan at lower field strengths because, as you can see here, for 3T versus 1.5T, the difference between fat and water is smaller, okay? So that pixel shift is gonna be less obvious. Okay, so imagine it's scanning at 1.5 versus 3, or even like at a 0.7, or even less than that if you have like an open scanner. That might be the best way to reduce that artifact. But we know that we're sometimes limited into what we just have in a particular department. So, you know, if you just have a 3 Tesla scanner, you have to think of something else. We want to keep a field of view to a minimum. And the main reason is basically we want to have a lot of pixels. We want our matrix to be very high. So what you could say here is also increase your imaging matrix. Because if we increase our imaging matrix, each pixel is going to be allocated a certain amount of frequencies, and that artifact will be less pronounced. But the most common one we see to remedy this particular artifact is what we say increasing your receiver bandwidth. Basically increasing, when you're collecting signal with that readout gradient, increasing the amount of frequencies, because remember, we know that frequencies can basically be collected, or echoes, with all different types of amplitude and how fast those frequencies are, basically, you know, cycles per second, things like that. So if we have our receiver gradient on top of the patient, we're getting all types of frequencies. It could be something like that. It could be something a little bit slower. It could even be something a little bit faster, just depending on how the MR system excited and refocused those spins. So we have all different types of frequencies. That's what it means by increasing receiver bandwidth. Okay. So when you increase receiver bandwidth, you're basically going to reduce this chemical shift artifact between fat and water, because they're going to be closer together in terms of your imaging matrix, compared to if your bandwidth is a little bit smaller. It's going to space out that pixel shift a little bit more. So let me go into a little bit more detail about that, and it's over here. So when we adjust our receiver bandwidth, basically we're going to determine your frequency range within a given pixel, okay? So imagine if your data points or your matrix is 256, okay? Remember, your matrix typically has two numbers. Let's say the 320 times 256, that's your imaging matrix, okay? Typically, the smaller number is your phase direction, and the larger number is your frequency direction. So in this instance, we had 256 frequency. So let's just give you a scenario where 256 is the larger number, and let's say 192 is your phase. So this is going to be associated with this scenario. So if we have 256 data points, or pixels, collected in the frequency direction, whatever we set our receiver bandwidth to, let's say we set a large or wide receiver bandwidth of 32,000 to start out. So what happens is basically each pixel will now have a frequency range of 125 hertz per pixel. And the way we got that number is basically we take that 32,000 and divide it by our frequency matrix. So this number right here equals that 125 hertz per pixel. Okay. We also need to know what type of scanner we're scanning on. So at a 1.5 Tesla, we know that fat and water process at 220 hertz apart. So to calculate how far apart fat and water are going to be spaced apart, or have basically how many pixels are going to be between them, we take that 220 and divide it by the number that we just calculated for. So 220 divided by 125, and we're scrolling down here. And that gives us our 1.76 pixels apart. So with that scenario, you get a situation like this. So you can see that it's not even 2 pixels apart. We're 1.76 pixels apart. So they're going to be right next to each other. So that artifact is not going to be as pronounced as, let's say, where we select a receiver bandwidth of 16,000. Okay? So let's try and calculate how many pixels fat and water are going to be apart at 16,000. So first we need to know the frequency matrix, and they give it to you here, 256. So let's do 16,000 divided by 256. What number do you guys get?
62.5.
Can you say it one more time?
62.5.
Okay, 62.5. Okay. And remember, that's hertz per pixel. All right, and you can actually see that number right here. So we have 62.5 hertz or frequency range within 1 pixel. You see that? All right, now let's calculate our pixel shift. So we take that number right here. So we know that at a 1.5 Tesla magnet, we have a 220 hertz separation of fat and water. So from our last example, we take 220 divided by 125, but we have a different number this time. So we take 220 divided by the number that we got, 220 divided by 62.5. And what's that number?
3.52.
3.52. All right. And you can see here that they shifts 3.52 pixels. Okay. So when the receiver bandwidth is low, we get a greater pixel shift between fat and water, which creates a scenario like this. Okay. Here, in this scenario, water's on this side, just because it's bright, you can tell, and then fat is on this side. And it creates this pixel shift where you have a bright and a dark edge. And that's what's going on here. Because our receiver bandwidth is too low, it creates a greater pixel shift between fat and water. Okay. So once again, this is an artifact we can't completely eliminate. We can increase our receiver bandwidth, and we can scan at lower field strengths. So those are two ways that we can reduce this artifact. We can also increase our field of view. We can increase the number of pixels or our matrix. That's another great way to reduce this artifact. And then finally, the last way to reduce, or actually to completely eliminate it, is if we just eliminate fat altogether. So if we fat sat or water sat a particular tissue, we're not going to get that artifact. Okay, so here is a fat sat technique of the abdomen, and you can see we do not get that chemical shift artifact around the kidneys because fat has been completely nullified. So all you see is water. All right, so let's go to some other examples. So this is just kind of what it looks like if you had chemical, if you were scanning a plastic cup filled with water, tray of water, this blue, and then you put a smaller Petri dish filled with just like vegetable oil or olive oil inside of it. And they do this sometimes to check the chemical shift on your MR scanner. And this is what it would look like on your MR scanner. You can see that water here and then the fat inside. And since those two things are processing at different processional frequency, it creates this chemical shift artifact at the interface. And what I mean by an interface is where fat and water meet. And typically it's going to be in the frequency direction. So I know the frequency direction is right to left. So there's so many things that I can kind of conclude about this image, just kind of looking at how the artifact looks, the appearance of it. Here, another great example of those axial kidneys, dark on this side, bright on this side, dark on this side, bright on this side. Here, you can actually see it when they're scanning in the coronal plane, bright on the medial aspect, dark on the lateral aspect. L-spine, already showed you that one, knee. You can even see it in the L-spine sometimes. Here on the superior part of the vertebral body, it's bright, and then on the inferior part of the vertebral body, it's dark. Very subtle. This is something you typically might not see unless it's very pronounced, like in the kidneys. Okay? And here is a femur. You can see it on where fat, adipose tissue meets muscle, more water-based, dark, and then bright on this side. It's kind of hard to see because the signal from the fat is bright also. All right, any questions about that? So main takeaway, this is going to be on the frequency axis, which is not as common. So make sure you really highlight this. This artifact occurs in the frequency axis. More often than not, these artifacts typically appear more on the phase axis. And this is something we can't completely eliminate unless we fat sat. All right, moving on. Chemical misregistration, also called out of phase signal cancellation, or just out of phase artifact. Right? We talked about this a little bit last week when we were talking about like the Dixon method and in and out of phase imaging. Once again, this is field strength dependent because fat and water process at different processional frequencies depending on the field strength. All right, so by definition, fat and water are in phase at certain times and out of phase at other times due to their processional frequencies. So we know that water going around this processional path is a lot faster than fat. Sometimes they line up, sometimes they don't, and then they come back into alignment. It's a very predictable path. And we know that since it's field strength dependent, we can actually kind of time this out where they're in phase, out of phase, and back in phase. So you guys get the in phase, out of phase thing first of all. That's kind of a big thing, right? In phase, we're talking about the shift, the phase shift of these spins. And you can see in phase, the vectors are pointing at the same direction along that processional path. And so see here how on the clock, the blue and the yellow align. And then due to the difference in processional frequencies, there's going to be a time period where they're out of phase with each other. So see how water is pointing to the left and fat is pointing to the right. And since this is very predictable, the same amount of time it takes for them to get out of phase with each other takes to get in phase with each other, and then they'll be back in phase with each other. This particular artifact occurs in both the phase and frequency directions. So you're going to see it in both directions. The appearance of this artifact on a out of phase image is basically a ring of dark signal around certain organs where fat and water interfaces occur within the same voxels. So a common area, kidneys, liver even, pancreas, a lot of those structures have fat and water within the same voxel. This artifact is most pronounced when we're using gradient echo imaging, because we don't have those 180-degree refocusing pulses to boost the signal back up. So this is this out of phase artifact. So look at these ringing, basically everything that is on this image has this like outer band ringing artifact. So everything, so for bowel, you have this around the kidneys, you have it even around the liver a little bit, you have it around the muscles, the vertebral body, kind of right out here near the subcutaneous fat. So all these structures have fat and water within those voxels, and it creates this banding artifact because they're being scanned on a gradient echo pulse sequence, and the TE is time that fat and water are completely out of phase with each other. Here's another example. You can see, look at this black. It just looks like somebody took like a Sharpie and just outlined all the organs so that they were going to color them in later on. That's what that out of phase artifact looks like. All right, so we use this to detect certain pathologies, and that can be with this Dixon technique. So we want sometimes to have out of phase and in phase imaging. So what we do to get that particular type of imaging, Dixon imaging, we set multiple TEs. So we have to have, you know, a fast spin echo where we sample multiple echoes per TR. So we select multiple TEs. And at a 1.5 Tesla, typically fat and water are going to be in phase with each other every 4.2 milliseconds. So you can see here water processing and fat processing. I would say that this is a little bit wrong in just how, from this particular diagram I drew from, I would put fat here and water here because fat typically processes a little bit slower than water. But besides that, this diagram is dead on in that at 2.1 milliseconds, they're going to be out of phase with each other. And then at 4.2, they're going to be back in phase with each other. At 6.3, they're out of phase. So at increments of 2.1 milliseconds, they're going to be either out of phase or in phase with each other. And typically on the even echo, remember even echo rephasing from our last lecture, on the even echo, they're going to be in phase with each other at echo 2, at echo 4, at echo 6. Okay? Another way to get rid of this artifact is instead of a gradient echo pulse sequence, let's just scan them on a spin echo. Spin echo, we have those 180-degree refocusing pulses, and it will compensate for the differences between fat and water. So this is what it looks like if you have a spin echo. So this is water decaying, and this is fat decaying. And what's happening as the signal's getting bumped up is you're having a 180. Bumps the signal of fat and water back up. And we have another 180, bumps the signal back up. So we know we have 180-degree refocusing pulses when we're scanning spin echo. But when we have a gradient echo, we do not have those. And so fat and water don't get their signal constantly bumped back up. And then this last little comment here is just to kind of show you that we can use this artifact to our advantage, because sometimes we want to just do fat only imaging or water only imaging depending on what we're scanning. So this is great for ruling out fatty liver, adrenal adenomas, things like that. So sometimes artifacts are good. It helps us really diagnose what's going on. All right, let me show you some more examples of chemical misregistration. So here we have an in phase up top, and look, there's no banding artifact, and then down below, out of phase. So we could say that this one occurred at 4.2 milliseconds because they're in phase with each other. So a TE of 4.2. This one occurred at 2.1 TE. Let's just say this is TE1. This is TE2. That's why they say even echo rephasing helps with this artifact. So just take note of this banding artifact around the organs. All right. Another example, abdomen, out of phase. Coronal abdomen, out of phase. Chest, coronal, out of phase. Gradient echo pulse sequence of a fetus, out of phase. Abdomen, once again, out of phase. All right. So several examples of chemical misregistration, also called out of phase artifact or out of phase signal cancellation. Any questions so far? All right, next one, truncation or Gibbs artifact. All right. This results from undersampling of the data. So undersampling just means that we don't have enough phase encoding steps, we don't have a large enough field of view, things like that. So undersampling of the data. So we have too few lines of K-space. So we don't have enough lines of K-space. So that interfaces of high and low signal are incorrectly represented on the image. So a perfect scenario of this would be a sagittal C-spine where you go from really dark, where the vertebral bodies and that posterior ligament are, to really high signal, where you have CSF fluid. And then once again, it goes back down to really low signal where the spinal cord is, and then boom, back up to really high signal. So that's where we're talking about these interfaces of high to low signal. So most common when tissue is still producing high signal at the end of data collection, or when peak echo is not centered in the middle of the sampling window. All right, so two different scenarios. So the first scenario, most common when producing high signal at the end of data collection. All right, so here, most of the time we think of how we're collecting data is very like, very square and just very, you put that signal into a box, it's very squared off, and it's easy for the system to kind of collect it and to put it into your image. But what's more likely is that, remember, we have these RF bands that we're collecting that are very rounded. And we're trying to put these very rounded RF bands into very square pixels, right? So what happens is this scenario where we still have, they say this is high frequency coming from the CSF. And as that frequency is high, it starts to dip down once we get to the spinal cord, but we still have a little bit of area right here that is still decently high. And so that gets mismapped into our spinal cord. So it looks like there's little streaks of bright signal into our spinal cord that kind of look like our CSF fluid. So that's what's happening when we get high and low signal right next to each other, and we're trying to put rounded RF pulses into square pixels. Okay. The second scenario, when we're talking about when peak echo is not centered in the middle of the sampling window. So remember, on our readout gradient, typically we have a dephasing lobe and then a positive rephasing lobe. Usually right in the middle is where that signal peaks out, and then it goes back down. This scenario is talking about if we have a very short TE, and instead of something like that, we just have a very short TE, and here's normally the middle of that readout gradient. And what happens is that peak signal doesn't happen until a little later on in that readout gradient. And when this happens, when peak echo doesn't correspond to the middle of that readout gradient, we get this artifact also, this truncation or Gibbs artifact. Okay? So this occurs in the phase direction because we're undersampling our signal in the phase direction. This is just kind of what I was drawing here. And this is what it looks like. So it produces a banding artifact at interfaces of high and low signal. So think very high signal CSF next to very low signal spinal cord. Rounded RF pulses trying to put in to be square pixels, and it creates, look at that little streak of high signal. That's concerning. I don't know if you guys, let me zoom in a little bit more. That is concerning because what pathology mimics that?
Syrinx.
Syrinx, very good. So we have, this is a T2 because the fluid is bright, but we also can see it on T1s where the fluid is dark. And then look at that streaking artifact that's dark in the middle of the spinal cord. Okay. And then we can also see it kind of near the edges of the brain where we get cortical bone, which is very dark, next to brain tissue or fluid that surrounds the brain tissue, which is very bright. And then you can see these streaking artifacts that kind of look like when you hit water and it produces this waving effect. Excuse me, where it just kind of creates this artifact that kind of looks like little waves that streak across the image. So very dark signal, very bright signal creates this truncation Gibbs artifact in the phase direction. All right, so you're thinking, how can I reduce this artifact? Simple, you just increase the amount of phase encoding steps. So you add more pixels in the phase direction. We're gonna, instead of being undersampling the data, now we're gonna sample the data at the appropriate amount. I also put on here, avoid using partial Fourier techniques, and that goes back to the K-space filling as we fill K-space. Sometimes, since K-space is very symmetrical, we just basically take whatever we got from the data up there and just replicate it into the area below. And that helps save time, but sometimes it makes these artifacts more pronounced. And then you could also just fat sat, because sometimes you're getting very bright signal from fat that can be streaking across the image. So 3 different ways of reducing that artifact. All right, so let me show you some examples of what it looks like. So here, perfect example, very dark cortical bone, very bright signal from CSF that's surrounding the brain. You guys see that, right? That rippling artifact? Okay. Here's the image I already blew up. You can see that rippling artifact. Here's seeing that rippling artifact on an actual phantom. So this is, once again, something that we can detect on when we're doing QA/QC. See that rippling artifact. Then they increased, they went from 128 phase encoding steps, or your matrix, to 256. And that artifact is almost unpronounced. That you could probably zoom in really good and see that artifact a little bit, but it's not as pronounced as 128 matrix. Here's that 128 matrix on a T1. There's that, they call it pseudo syrinx because it mimics that pathology. And then look here, this is that frontal lobe cortical bone next to CSF fluid in the frontal sinus, or not CSF fluid, fluid in the frontal sinus. And it mimics, or it creates this truncation artifact. Same thing. All right, moving on. We'll do one more. Any questions about truncation or Gibbs? All right. Very important artifact because you see it all the time. Metal susceptibility. So there's really no other name for metal susceptibility. This is really dealing with any type of metal that we put into the scanner, but we know that ferromagnetic metals, they're most attracted to our static magnetic field, and so they're going to create the biggest artifact. So let me just repeat that. Typically, any metal will create an artifact, but the ones that create the largest artifact are going to be our ferromagnetic materials. Okay? So think iron. All right, so what's happening is different tissues magnetize to different degrees. So, you know, our body has all different types of tissues, and we know that they're usually moving at a little bit different precessional frequencies. And so they're going to also magnetize at different rates too. So our muscle is typically a little bit more conductive than like fat, which is more of like an insulator. So certain tissues within our body actually magnetize a little bit easier. And what's that's going to do is it's going to cause those slight changes in phase shift between those tissues to really be highlighted. They're going to change even more in their phase directions between those two tissues. And we know due to intravoxel dephasing from last chapter, where if we have a voxel where we have a bunch of different phase positions, it's going to just decrease our overall signal. So we're going to get signal loss. So that's why we get black, because we get signal loss because of that metal. But we also get this warping or distortion because those ferromagnetic materials are changing the lines of flux of our superconducting magnet. So we know we usually have a solenoid coil within our bore of our magnet, in our superconducting magnet. And then we usually have lines of flux that kind of go out like this, like big elephant ears, right? And they kind of expand out. It's equal on both sides. So not the best drawing here, obviously, but you want these magnetic flux lines to be very symmetrical, like elephant ears, and they get, you know, larger as they go out. What happens if you incorporate like a hip replacement in that scanner? So imagine your patient is here. You got your legs, you got your arms, and that hip replacement is right here in the leg. It's going to attract, because it's ferromagnetic, it's going to pull this flux line closer to it. And when you pull and distort these flux lines, it's going to distort the anatomy on our image, because it's going to change our spatial encoding. It's going to change our precessional frequencies. So it's going to make the anatomy look a little distorted. So right here, we know from x-raying many, many knee replacements, right? Typically that knee replacement just kind of has this very straight edge. And then it has like a metal part that goes down in the knee. So we get signal loss because of the metal due to dephasing, but then we get this added like distortion area because it's changing our magnetic flux lines. Okay? Because it's that metal is attracting those magnetic flux lines. So we know certain metals should never go in our MR scanner, right? Thinking like ferromagnetic aneurysm clips, anything like ferromagnetic pacemakers, because that could really harm the patient. But you also are able to scan non-ferromagnetic metals, which won't hurt the patient, but they still cause an artifact. So this might be a titanium hip replacement, but it's still going to cause an artifact. Because once again, those magnetic flux lines are going to be attracted, and you're going to get dephasing of those spins to create a signal void. Okay, so it's our job. Obviously, we can't just go, oh, you got a hip replacement, we can't scan you. No, you know, we have to compensate for these things sometimes. Sometimes you can remove the metal, like dentures, right? You guys sometimes have scan and you have to make sure they remove their dentures so they don't create that massive artifact in the brain. So we do have the luxury sometimes removing the metal. But the main things you guys need to be thinking about are, all right, I need to be choosing a turbo spin echo versus a gradient echo sequence, because those multiple RF 180-degree refocusing pulses help compensate for those field inhomogeneities better. So if you have a choice, we want turbo spin echo over gradient. We also want to use stir over fat set. And we talked about that last time because we get a more uniform fat suppression, because this is dealing with inverting pulse versus what we call a chemical or spectral fat sat, where that deals with the precessional frequencies. We could also use a wider or a larger receiver bandwidth. So remember, think that 32,000 receiver bandwidth, because this restricts our artifacts into a smaller number of pixels. We get less what we call pixel shift of that metal artifact. So a larger receiver bandwidth helps allocate that metal artifact into a smaller number of pixels. We could also increase our matrix or decrease our field of view. Once again, both of those things increase our spatial resolution, but it makes our pixels smaller. So that artifact is going to be, you know, through less number of pixels. We could choose a thinner slice, and then overall we could just decrease our TE. Because if our signal is rapidly decaying due to that metal, we want to select a TE that's a lot shorter and longer so that we get less signal loss. So this is the one we're going to want to select. Right? So really important to remember the remedies for this, because you'll see this a lot when you're scanning. Most of the time, hopefully it's not the area that you're looking at. So usually if they're doing like a knee, they're typically not doing the knee that has a replacement in it, but sometimes you do. And you have to really make sure you minimize that artifact, because they might not be looking at the bone here, but they might be looking at like the ACL joint ligament that runs like right here. So you need to make sure you're able to see that structure instead of the bone. Okay? So let's just take a look at some metal artifacts. So a very common one here on the left is like dentures or braces. So you can see the signal void, but just look at this like warping distortion of the anatomy. It could even be just like a ferromagnetic metal in their tooth, because we know we have some metals that they fill cavities and things with.
I have a quick question.
Yep, go ahead.
So with a turbo spin echo, when you're thinking about a Siemens, we have a turbo factor that we can change. I just don't want to get them mixed up, or I want to make sure I understand it correctly. So I was asking about it.
Yeah, so turbo factor can also be called the echo train length. So if you see both of those acronyms, you should always be thinking turbo spin. So turbo factor, echo train length are basically how many of those 180-degree refocusing pulses you have. Okay. Turbo spin echo is just the name of the pulse sequence. Turbo factor or echo train is the number of RF pulses, refocusing 180-degree RF pulses you have per TR. Good. All right, so we solved the dentures. Here is a pediatric patient with a bullet, which sounds tragic already enough. And you can see how that bullet creates this metal artifact in the front of the abdomen. So they determined that particular, or maybe they swallowed it, because look, it's kind of in the bow. Might not even be a bullet. Who knows what that is? But that kid swallowed it, or hopefully didn't get shot, but it's creating this artifact. Here, a very common one with the shoulder, rotator cuff surgery. They sometimes, you know, they repair that particular tendon and then they kind of staple it down with like a metal screw or something. Total knee replacement, we know that creates a large metal artifact. Here's possible aneurysm clip. So you'd be really scared if you didn't know the patient had this, and then now they're in the scanner. Now you need to think about, oh my God, how do I get the patient out without hurting them? And sometimes the best thing to do is call your MRSO, your safety officer, and because the best thing to do is sometimes not what you would think. And in a scenario like this, sometimes you move the patient out, but you move them out very slowly so it doesn't rotate that aneurysm clip and burst that vessel. So several examples of metal susceptibility artifacts. So just remember, signal void along with distortion. So it doesn't look like the normal anatomy. All right. So we'll pick up from there next week, and we'll do just like a little bit of a game at the end of next lecture. But we have 1, 2, 3, 4, 5, 6, 7, 8, 9. So we have a couple 9 more artifacts, but they're a little bit shorter in their explanation. So we'll cover the rest of those artifacts next week. And then we'll play a game where you basically just need to kind of quickly identify the artifact and which direction or axis does it typically occur on. And then maybe you'll talk about how I can remedy that artifact. So we'll play a game. So make sure you have this chart readily available. All right, let's take a 10-minute break. 15-minute break. Let's reconvene at 10:10. Get you guys some coffee, and we'll talk about lower extremity. Anybody have any questions at this point? All right, I'll see you guys at 10:10 then.